Welcome to part 3 of respiratory system pathology. We're going to begin our discussion talking about the family of pulmonary diseases known as COPD. COPD, or chronic obstructive pulmonary disease, is a form of persistent obstruction of the airways that usually causes a difficulty in emptying the lungs of air. So, in other words, COPD causes the lungs to have a difficult time with that gas exchange in the alveoli. It may be caused by emphysema or chronic bronchitis, which are two examples that we'll look at today, but smoking is the predominant cause of COPD. Mild cases of COPD usually are not detectable on chest x-rays, but more severe conditions are much easier to spot. Again, COPD is a family of pulmonary diseases, usually caused by smoking, not always. And we are just looking at two examples. So I don't want you to think that emphysema and chronic bronchitis are the only examples of COPD. Those are just the two we're going to look at in this lecture. Okay, let's begin by looking at emphysema. Emphysema is an irreversible and chronic lung disease in which air spaces in the alveoli become greatly enlarged due to destruction of the alveolar wall and loss of alveolar elasticity, or the ability to contract and expand. So let's say that one more time. Emphysema occurs when the alveoli become permanently distended or overexpanded, overinflated. Patients with emphysema have a hard time expelling that carbon dioxide. There's no gas exchange occurring anymore in these overinflated alveoli. As a result, our patients have a difficult time breathing. The number one cause of emphysema is smoking, but you also see emphysema in patients that had long-term dust inhalation. So smoking is not the only cause. It could be occupational in nature as well. In severe cases of emphysema, you will be able to see that on a chest x-ray because the patient will have depressed or flattened hemidiaphragms. And let's think about that for a second. Here is an axial slice taken during a CT scan, and you see these dilated or distended pockets of gas in the lungs. Severe cases of emphysema will cause these pockets of gas to eventually flatten or push down on the hemidiaphragm. And so instead of having that nice round base in the lung that we see on chest x-rays, you'll see that hemidiaphragm is flattened or pushed down. That is because of these distended pockets of gas in the lungs. Okay? The lungs appear very radiolucent, which means we don't see the parenchyma, we don't see the lung markings. And as a result, it's really important in patients with severe emphysema that we decrease our technique because we're just shooting through straight air here. If we use too much kVp and too much mass, we're going to overexpose or overpenetrate these lungs. So, to recap, patients with emphysema have permanently distended alveoli. That can appear on chest radiographs and CTs as large pockets of radiolucency because there's no parenchyma, there's no lung markings, and we have to reduce our technique in order to avoid over-penetrating the lungs. Okay, good. Let's look at chronic bronchitis. This is a long-term condition in which excessive mucus is secreted into the bronchi, causing coughing and shortness of breath. The chief cause of chronic bronchitis is cigarette smoking. Infectious bronchitis, however, can be caused by viruses or bacteria. Bronchitis usually involves the lower lobes of the lung And in severe cases, it's demonstrated on radiographs by hyperinflation and dominant lung markings. You don't need to write that down, just for your information. Please connect chronic bronchitis with long-term inflammation of the bronchi, okay? So those are two examples of COPD. As I said, there are certainly more, but I want to go on next to discuss a genetic lung disease, specifically cystic fibrosis. Cystic fibrosis is the most common genetic or inherited lung disease, and it is a condition in which secretions of heavy mucus clog the bronchi and the bronchioles. Now, this may be evident on chest x-rays as increased radiodensities, which you can see here. So that is the mucus clogging the bronchioles. Now, the average life expectancy of a patient with cystic fibrosis is only 35 years of age. And you think about this makes sense. If you have heavy secretions, heavy mucus clogging the bronchi, breathing is going to become impossible eventually. So this is a really sad, and I've worked with patients with cystic fibrosis, and this is very sad to see someone so young suffer. But again, this is a genetic and inherited disease, which, makes it even more scarier. It's not influenced by our behaviors or our actions. Okay, next, let's look at lung neoplasms. We are going to talk about a malignant lung neoplasm in this discussion, but I want you to remember that neoplasm simply means new growth, and it could be benign or malignant. So whenever you see the term neoplasm, please do not always assume it is malignant, okay? So we're going to talk about lung cancer, and many types of lung cancers have been identified, but more than 90% of lung cancers start in the bronchi, and we call that bronchogenic carcinoma. Less common, we have alveolar cell carcinoma. You don't need to write this down, but that type of cancer originates in the alveoli of the lungs. Also, many lung cancers actually start somewhere else in the body and spread to the lungs as pulmonary metastasis. So if a cancer metastasizes, that means it's spreading to other parts of the body. So some lung diseases, or lung cancers rather, may not be primary lung cancers. They may be lung metastasis. Advanced cases of lung cancer appear as large radio-opaque masses, and I'll show you an example in a second. CT is a helpful modality for revealing small cancers that you can't detect on chest x-rays yet, so CT is very helpful in those instances. And if a patient has a neoplasm that is suspicious, the radiologist will typically recommend a biopsy. So let's look at a malignant lung neoplasm. So a malignant lung neoplasm is a cancerous growth or tumor in the lungs. And in this patient, you can see a large tumor here in the left lower lobe of the lungs. This would probably be biopsied. The sample of the tumor would be sent to lab where they would determine if this is cancerous or benign. And then certainly if it's determined to be cancerous, the patient would be referred to oncology where they could develop a treatment plan. All right, we're going to pause here and we will pick up with miscellaneous lung diseases in our next lecture.